which focuses on mental health and the workplace, which of course has been a topic of great interest, especially over the last couple of years with COVID impacting how we all work. So it's we've got two wonderful speakers to speak to this issue today. And the first is Professor Tony Lamontagne from Deakin University. And Tony is a Professor of Work, Health and Wellbeing at the Institute for Health Transformation and the School of Health and Social Development at Deakin in Melbourne here in Australia. And he also holds appointments with University of Melbourne, Monash Uni, University of Massachusetts, and at the Institute for Work and Health in Toronto. He himself leads a small research unit in work, health and wellbeing, and from 2020 also has served as the director of the Determinants of Health Research domain in the Institute for Health Transformation. His primary research interest is in developing the scientific and public understanding of work as a social determinant of health, and then translating this research into policy and practice to improve workplace and worker health. He has an international reputation for cross-disciplinary applied epidemiology and intervention research in work and mental health, occupational health and safety, and health promotion. Welcome, Tony. I'm looking forward to your presentation.
Thanks very much, Greg. Good day. I'm just going to share my screen and then we can get underway. There we go. That's coming through. That's visible. Greg, you can see that? Yeah?
Yeah, that's good. Perfect.
Great. Excellent. Well, as you heard, I'm Tony Lamontagne, and I'm going to talk today about an integrated approach to workplace mental health. Now, my normal controls don't work with this. How do we switch slides? There we go. So in the workplace, most of you will be aware that mental illness is common in the working population. At any point in time, about 1 in 5 workers is affected by mental illness, most of which are mild to moderate, usually depression or anxiety. Some are more severe, the darker silhouetted figures in this portrayal, things like bipolar or major depression. So this is a very common phenomenon that people suffer from mental illness at work. So what are the impacts and implications of that situation? Well, for individuals, there's issues of the potential for discrimination and losing one's job and getting reemployed. For organizations, most think about productivity and organizational performance. At the societal level, there's a growing problem with early exit from the workforce onto disability pensions and other statutory insurance systems. That includes, for example, workers' compensation, where stress-related or mental injury claims are one of the largest groups and one of the only categories that's growing. And in the law and policy space, there is an occupational health and safety obligation to provide psychologically safe work to the extent feasible. And there's also a number of other legal and ethical mandates in this space that coincide in the area of workplace mental health, such as anti-discrimination, equal opportunity, disability employment, and other employment law. Oh, gosh, these controls, sorry about that. Trying to get that right. So in the face of this, about 15 years ago, I started working in this area. And initially, I had much too much to say with far too much detail and not enough of the higher level understanding or a higher level way to give people access to a complicated area. And so we put our minds to trying to distill down to its essence what we needed, what we wanted people to do in the workplace. And this was to provide a starting point for stakeholders in the workplace, from workers to managers to OH&S staff, that was relatively jargon-free and accessible and would provide an entree into the area. And this is it. It basically says that to address workplace mental health, there's 3 areas of action that need to be addressed. Preventing harm from work. You can also prevent harm that's through promoting non-work related activities such as physical activity. And then there's promoting the positive, which is promoting the positive aspects of work as well as worker strengths and capacities. And then when mental illness manifests in a workplace, you need to respond whether it's work related or not. And so those 3 areas are the essence of what needs to be addressed workplace mental health. And there's a commentary from my dogs. Sorry about that. So the legal requirements, how does this address legal requirements? Well, the prevent harm is an OH&S regulatory mandate, and responding to mental health problems, it falls under anti-discrimination and equal opportunity law and others. Promoting the positive is really is a voluntary thing. It's not required by any law, but as you'll see, there are good reasons to do it later on in the talk. Importantly, this integrated approach is a framework only. It says what to do. It doesn't say how to do it, because the way to do these things takes very different forms depending on the work context, the workers you're dealing with, whether you're in a unionized or a non-unionized, a large or a small business, the nature of the business, whether you're a teacher or a police officer or a convenience store clerk. So the activities that might constitute an integrated approach could be a handful, or there could be many in a large organization with a well-developed program. So now let's go through each of these threads individually and just point out that the three threads come from three different disciplinary perspectives that we're trying to pull together in this integrated approach. Preventing harm is really more from an OH&S perspective, occupational health and safety. Promoting the positive is sort of the new kid on the block, informed by positive psychology, by management sciences and organizational development. And then the managing illness aspect was really from a medical perspective, an illness perspective, medicine, psychiatry, clinical psychology, for examples. And stating this in words as opposed to the picture, it's important to note that in protecting mental health, the first point of attention should be on controlling work-related risks to mental health, but also one can promote other activities that would address mental health problems that are not related to work, such as offering gym memberships through employment, for example. And promoting the positive is about developing positive aspects of work. And again, that should be the primary focus of employers, but it's also about developing worker strengths and positive capacities. And as you'll all probably be aware, there's been a huge takeoff and a focus on resilience, which tends to be individually focused, but could be focused on making resilient organizations. We'll speak more about that as we get into the talk. And then finally, addressing mental health problems regardless of cause is quite important. You can think of this as responding to problems, managing. Responding can be as simple as checking in on people, embodied by the Are You OK Day. That's very well known in workplaces these days, all the way up to return to work from a mental illness. So now let's do a quick tour through each of the three arms or threads of the integrated approach, starting with preventing harm. So you'll all be probably aware that work and working conditions can be good for you and bad for you. Most of you have probably experienced a little of each. And the positives of work include it being a primary source of income for most people. It's a source of identity, self-esteem, social connection, sense of purpose, belonging, time structure. There's various benefits to good work. However, the aspects of work that can be potentially harmful to mental health include psychosocial work stressors are the largest group. Excuse me. And these include things like the level of control you have in performing your job, the level of demands or effort required to get your job done. Job strain is the combination of high demands in the face of low control. That's been extensively studied, roughly doubles the risk of depression. Social support at work is protective, and so on. I won't go through the entire list there. This list is partial only. So to understand that these stressors, there's a huge body of evidence linking these stressors to mental health problems, and outcomes include generalized distress, depression, anxiety, burnout, and suicidal ideation, as well as suicide mortality. So to take one particular stressor and detail it, job strain, that combination of low control and high demands, nearly doubles the odds of incident depression. And because job strain is a common exposure in the working population, 15 to 20% of the population is exposed, this translates to a large preventable burden of mental illness. So we've done the epidemiology here to estimate the fraction of depression in the working population that would be attributable to job strain. And these are the figures. In Australia, from 10 years ago or so, for nearly around 15% of the working populations, higher in women because women are more exposed to low job control with persisting disparities in the workplace, mostly sexism related. In France, we get similar numbers from again about 10 years ago. And most recently, this exercise has been repeated across 35 European countries, getting pretty much the same answer: 15% or so of prevalent depression. That's one stressor and one mental health outcome. And of course, there are many stressors in people's working lives, and there are many mental health outcomes. So this is just a glance into the impacts of poor working conditions on mental health. So turning now to what can we do about it? Well, what to do is reasonably well established, that if you take an approach which addresses primary, secondary, and tertiary prevention, or another way to describe that is combine work-directed intervention with worker-directed intervention. Worker-directed strategies would be things like building resilience, for example, stress management and prevention. These phrases all basically describe a similar approach that's multi-level and comprehensive, and each of them is key to involve the people who are being intervened on in the design of the intervention, taking a participatory approach. And that's essentially an enactment of job control, if you will. And so there's evidence of impact on stressors, reducing stressors from these approaches, as well as improving mental health. Now, how to do this is more challenging in a given work context. The principles are common, but the solutions are all unique. As we described a little bit earlier, things are going to look very different in optimizing job control for a convenience store clerk versus a teacher versus a construction worker. And so tailoring is always important and the context dependent. So even if it's the same sector, you might have a unionized or a non-unionized or a male dominated or a female dominated group. And all of those things would play into the design of your particular workplace mental health program. In practice, this isn't what tends to happen, though things are getting a little bit better. There's a persisting view of the problem as individual-based, or sort of stigmatizing job stress, as well as stigmatizing mental health issues. Sort of notions like you can't stand the heat, get out of the kitchen. And work stress and mental health problems have been characterized as stereotypically feminine weakness, including by women interviewees in qualitative studies. And the most prevalent response is to have an employee assistance program, an EAP, which is a valuable thing, but in and of itself, it's a responsive, reactive strategy. It's not preventive, and it's one important element, but it's insufficient in and of itself. And our insurance-driven responses can conflict with public health need. So the first responses of most workplace regulators in the 90s, 2000s was to try to make it harder to file stress-related claims. And suicide was not discussed in relation to work for many workplace regulators as short a time ago as about 10, 15 years. So we have come a long way, but we still have a little ways to go. So to summarize that arm of preventing harm, it's stressor-based, it's strong on primary and secondary prevention, stronger on the environment, little on promoting the positive, and there's a disconnect between best practice and prevalent practice. So now let's turn to promoting the positive. A couple of definitions that many will be familiar with. This is about complete health as opposed to absence of illness. Oops, what happened there? Sorry about that. The WHO definition, many will know, is a state of complete physical, mental, and social well-being, not merely the absence of disease. And then we can also talk about well-being or positive mental health, focusing on social and psychological functioning and positive feelings and emotions. And Corey Keyes has detailed a model of positive mental health or flourishing as being high well-being in the absence of mental illness. So what do we know about these, about well-being in the workplace? Well, there's a large literature, and to link this to the previous topic, what we do know is that job stressor exposures can also erode well-being as well as increase risk of illness. It's only a couple of studies to date, but what we've seen is that the stressors are more strongly related to well-being than they are to negative mental health states. One positive thing is that to the extent that one brings positive mental health to work or work produces positive mental health, it is protective. People with stronger resilience or positive mental health are less affected by job stressors than those without that. So that's potentially a positive aspect there. What are the goals with promoting the positive? The overall aim is individual and organizational flourishing. And to do this, one uses positive approaches as opposed to deficit oriented OH&S reduction avoidance sort of goals, and really going after aspirational or approach goals to encourage or develop, for example. What are those? Some of those methods are known as appreciative inquiry, future search, strengths-based development, and these are applied in pursuit of positive outcomes such as well-being, eustress or challenge, EU meaning true stress as opposed to distress. Positive stress is a favorable thing, and then positive employee capacities and organizational attributes. Some examples you will most likely have heard of: mindfulness, psychological capital development, gratefulness in the workplace. And most of these, however, have been individual directed strategies, and what is developing is more of a focus on the organization or the culture, such as positive manager behavior strategies, workplace social capital, and building a culture of respect. What's the evidence that this promotes well-being? In the large general literature, not restricted to workplaces, there's evidence of positive effects on well-being, as well as protective effects on depression. In now almost 10-year-old review of 15 workplace studies, there was evidence that it enhanced employee well-being, mixed evidence that performance was enhanced, and limited evidence of reducing negative outcomes. A more recent study, just from a couple of years ago, of workplace mindfulness interventions showed that beneficial effects for reducing stress and anxiety and promoting well-being. There was another umbrella review a year or so later, which rehashed a lot of what you just heard, but in addition, there are relatively few studies aimed at improving the positive aspects of work itself, which is where, from my own wish, would be that that's where we would put most of our attention. There are a number of such strategies that have been piloted, evaluated in individual studies, things such as working time control, job crafting, where you involve the individual in redesigning his or her job, stress management, well-being focused management training, and so on. And these, however, have yet to be reviewed in a systematic or a meta-analysis. So in summary of the promoting the positive arm, we can say that well-being can be eroded by poor working conditions, as well as increasing the risk of illness. Positive mental health, however, may mitigate or moderate the effect of work-related psychosocial hazards on ill mental health. There's a limitation here that most of the evidence to date has been individual, and most of the practice has been individual directed, but that's moving to team, group, or organizational level, which is positive, and this is the least developed of the three threads of the integrated approach. So now on to the third arm, responding to mental health problems. There's a very wide range of activities that fall under this domain, ranging from early detection or simple, how are you going, all the way up to helping behaviors, return to work, and disability employment. What I'm going to focus on in the talk, just for brevity, is mental health literacy and anti-stigma interventions, which have been a big focus of workplace mental health programs over the last 15 years. Mental health literacy is defined by Tony Jorm as the knowledge and beliefs about mental disorders which aid their recognition, management, or prevention. So what this involves is training to raise awareness and try to reduce stigma, and also to provide skills for help offering as well as help seeking for oneself. Examples of these include, mental health first aid, Beyond Blue's National Workplace Program, Are You OK Day, which I've mentioned earlier. A real positive of this is that workplaces have taken it up very enthusiastically. What's the evidence of effectiveness of these strategies? It's been a meta-analysis of 22 workplace mental health interventions where, and this is dated, but still there was some small positive overall effects of intervention, reducing symptoms of depression and anxiety. More specifically, mental health literacy and mental health first aid interventions have been shown to improve mental health literacy and in some cases mental health. And there's mixed results on reducing stigma through workplace interventions. Touching on another thread of responding to mental health problems, optimizing return to work from mental illness. This was a study that we completed recently where we were focusing on workers' compensation claimants for a psychological injury or a mental injury versus a musculoskeletal injury. And what we found was that there's faster return to work for people out on musculoskeletal claims, and there's more supportive supervisor responses to musculoskeletal injuries, more consultative return to work planning, and more offers of accommodation for people with musculoskeletal injuries. That's compared to the mental injuries. And so in theory then, if we could improve these modifiable determinants of return to work for mental injuries, we could narrow that disparity. So in summary then, on responding to mental health problems, very illness focused, stronger on the tertiary end, weaker on the primary, strong on the individual, weak on the organization, little on promoting the positive. The evidence of evidence effectiveness is building, and it's very strongly embraced by employers. So that's the very quick tour of the integrated approach. And now we'll just touch on a couple of further elements and finish this segment. So this approach can also be expressed as a refined definition of mental health literacy as applied in the workplace. And you can see the elements of the integrated approach here when we define it as the knowledge, beliefs, and skills that aid in the prevention of mental illness and the promotion of well-being in the workplace, and the recognition, treatment, rehabilitation, and return to work of working people affected by mental illness. This is happening to various degrees internationally as well as here. Beyond Blue's national program probably really didn't address promoting the positive so much, but it did strongly address the other two elements. And there's some couple of examples from the UK and Canada that are also doing integrated approach to some extent. We've developed a number of resources that have been published open access for people to use. And I do have a resource list that will follow the talk and can be posted on the website. This approach appears we did succeed to some extent in distilling the essence of a strategy for addressing workplace mental health because it's been taken up widely in policy and practice. In the Victorian Public Service, Beyond Blue has used it a lot in a few of their guidance documents. It's being used in a guide that's being developed at the WHO, and most recently, the National Workplace Initiative at the National Mental Health Commission is using a similar approach. There's a blueprint or a framework that was just published for the National Workplace Initiative, and the comment period is open until November 26th. For those who are interested and would like to have a look at that, we welcome comments. I served on that panel as well. Cautionary notes about the integrated approach. There is still an overemphasis on the individual and an underemphasis on improving the quality of work. There is a risk of conflating mandatory and voluntary employer responsibilities. So there's lots of sort of resilience programs that are not doing much at all about improving working conditions. And that's out of balance. There are confidentiality and privacy issues whenever we're dealing with mental health, of course, and that you need to tread carefully. And there is often too much of a focus on softer targets. It's okay to start with improving communication, but it's also important to have a longer term view about how to improve job control at work or provide higher job security, particularly in the time of COVID. And at the population level, there's a real problem because those most in need are the least likely to receive attention of the sort we're describing here. So picture your casually employed workers who receive precious little training and have probably some of the worst working conditions. And this can in fact exacerbate inequalities in something called the prevention paradox. So just to finish now, the integrated approach to workplace mental health could increase the reach of job stress and mental health literacy intervention. It could rebalance the focus of work and worker, pushing it more towards focusing on work. And of course, there can be transferable skills. Mental health literacy is as useful outside of work as it is at work. And it could improve mental health well-being. And ideally, we may be able to see preventive synergies as a result. Just an acknowledgement of some of my collaborators over the past, and thank you. That's it from me.
Thank you very much, Tony, for a fascinating presentation. I personally would love to open up some discussion with some of the topics you've raised, but we don't have time now. So thank you very much for your fascinating presentation. Next up, we have Associate Professor Eva Kint, who is an internationally recognised expert in human resource management and development. She's a member of Swinburne University Technology Policy Hub, the Centre for Transformative Innovation, and the Department of Education and Training Science at the University of Antwerp in Belgium. Her research focuses on the intersection between learning and working. She has a profound interest in sustainable careers and focuses on lifelong learning and well-being of prospective employees. Her research interests include preparing graduates for sustainable careers, social networks in organisations, well-being at work and workplace learning. She's advised a diverse range of organisations, including being a contractor for the World Bank, and supports the product development of several evidence-based digital tools in the area of sustainable careers, hybrid work and well-being at work. I'm really looking forward to Eva's presentation.
Thank you, Greg. I'll start with sharing my screen. So this should be working now. So thank you, Greg, for the introduction as well as the invitation to talk here today. My talk has actually been really set up well by the previous talk from Professor Lamontagne, and I want to talk a little bit about well-being at work, but I want to go beyond that individual approach, because as Professor Lamontagne said, there's really much emphasis on that individual, while we have been examining how social contagion of burnout at work is happening. So we know already a lot. If you look at the traditional perspective on well-being at work, it's that individual-based emphasis. And we look at what the outcomes are of being well or not being well at work. So we've seen that symptoms like heart palpitations, lack of sleep are really occurring when you're not feeling well. But also it has an impact on the organization in terms of staff retention, absenteeism, etc. This is also, like Professor Lamontagne, a very, very partial list. Looking at what causes us to feel well or not that well at work, traditional factors are that job strain, so that job control and job workload combination, as Professor Lamontagne talked about. But also we know that the leaders are having a very important impact there, and then the social relationships. And it's the latter I want to zoom in on, because if we look at our own social environment, there are many, many people there. Some of them are a little bit more closer to us, some of them are a little more distant from us. They're also very different, the type of persons we interact with. And some have a good relationship, some have very positive impact on how we feel and how we act and how we feel at work and in our careers. Others, unfortunately, not that much. And then, of course, there's a lot of interactions that are occurring that are quite neutral. But again, looking at this complex issue, it's not like everybody has a one-on-one relationship. Those people we are interacting with are also interacting with each other and also hence influencing each other, which may in turn, again, influence our relationships with these persons. So if you want to look at that whole picture, the whole network, and how all of those different interactions, social interactions come together and have an impact on our own well-being, we're actually analyzing social networks. And this is a very important thing because I am part of the Social Network Research Lab together with Professor Dean Lusher and several more colleagues. And this is actually where the expertise of this specific research group lies, is in this analysis technique. And this starts from three basic assumptions. Looking at, for those that do still remember those horrible statistics courses from the graduate and undergraduate programs, a lot of statistical analysis actually assume that our observations are independent from each other, so that we are not influenced by each other. Social networks actually take the opposite perspective, and we are interested in the fact that people are interdependent from each other. Why? Because we believe that resources are flowing through our relationships, flowing through our interactions, resources such as knowledge, expertise, etc. But also we are embedded in social structure, and this structure actually offers us opportunities or constraints, or also shapes our actions and behaviors, and to some extent also the attitudes. And it's the latter that is especially important for this talk. More specifically, we're going to look at two specific social processes that are occurring in networks. And the first is called social selection. And it actually talks about which connections are more likely to form than others. And we know from prior research that it's more common and more likely that we will form connections, relationships, or that we will interact with people that are more similar to each other. So translating this to a well-being context, we would say that if you're not feeling that well, you tend to form a relationship or tend to interact with people that are also experiencing some troubles. You know, the person that really understands how you're feeling, what you are going through. But on the opposite, if you're feeling well and you're very energetic, you tend to attract also other people that are very energetic. That's the social selection aspect of the network. But of course, all networks usually typically already exist for a while. And when we interact a lot with people, we actually experience social contagion. And that means, very simple put, the more you interact with people, the more similar you become, the more in sync your attitudes are going to be. So in this, and that's also the hypothesis we investigated in our research. So the more you interact with people that are feeling well, that are energetic, that are very positive, very far away from burnout, which was a topic of our study, the less you are at risk of also developing burnout. And also vice versa. The more you interact with people that are experiencing those burnout symptoms, the more likely it is that you might also start to experience those symptoms. So you might say, well, why don't you just look at the organizational structure? Why bringing a new analysis technique? And why not look at the teams that are shaped by the structure of the organization? Why not take the org chart as a starting point? Well, in some parts of our research, we have done that, and there's definitely value in that. And it's definitely also very actionable for an organization to do that. But it's only half of the story, because in reality, our org chart usually doesn't really represent how our organization is working. And we can really identify networks that are very different from that org chart. As such, our network analysis gives us a way, an evidence base for really understanding how that organizations are working, how people are really and truly interacting with each other beyond their formal departments. Okay, this was a very crash course in network analysis and why we are taking this perspective. So what have we found on the social contagion of burnout? Well, first, of course, what do we mean with burnout? We're following the traditional definition from Maslow and identify three components, three elements to burnout, with emotional exhaustion being the basic layers. So feeling tired at the end of the workday, lacking energy, even at the start of the workday. You can't get a diagnosis of burnout if you don't experience that emotional exhaustion. And it's always combined with two or one of the two other elements. And that's depersonalization, really taking a distance, not being really committed to your work again, but also think of the teacher who chose to become a teacher because of the connection he feels with students and how he or she loves to see students grow. All of a sudden, taking that mental distance, not really bother too much anymore about what happens to the students. That's a clear sign of depersonalization or cynicism. But on the other hand, the lack of personal accomplishment, feeling like you're not doing a good job anymore, like you've somehow over those years lost the ability to perform well at work. As I've mentioned, emotional exhaustion is the base layer. So if you're experiencing lack of personal accomplishment in combination with emotional exhaustion, you might get a diagnosis from a professional, not just by submitting or filling out a questionnaire, but really go and see a professional for that one. But for example, say you've scored low on both personal accomplishment as well as depersonalization, but you don't experience those emotional exhaustions. It's not that it's not the right moment for you to reach out and help, but you likely won't get the diagnosis of burnout. This, I've told you, this is traditional definition of burnout by Maslow, but my former colleagues of the University of Leuven have actually worked hard on a new definition, which is a bit more nuanced and fine-grained. So if you want to learn more about that conceptualization, which wasn't in place yet when we did this study, definitely have a look at the website burnoutassessmenttool.be, or also nicknamed the BAT. But of course, our study here is this also a socially induced phenomena, burnout? We took this approach because there's a lot of research supporting the emotional contagion literature. And it says that you actually, by interacting with each other, you converge emotionally as well. And this happens through both conscious processes of tuning in, really listening to people, their stories, or how they're struggling with certain aspects of their work, but also observing them. If you see someone struggling, usually you're affected by it. Usually you tend to feel, you tune into those emotions, and it doesn't have a really good impact on your own feeling. Some are better than others in taking the distance, but still it's a conscious way of really tuning into how the others are going. But also unconsciously, we tend to mimic behaviors and emotions, but also absorb both verbal as well as non-verbal feedback. And all of those processes together over time through repeated interaction tends to have an impact as well on our attitudes and our feelings. So what did we do? We did a study, a pretty large scale study, given the fact that we're collecting social network data in 14 different schools in Belgium, including 931 teachers, and we measured burnout, and we measured 2 different networks. One more work-related network, where we asked teachers where and from whom do you get information about your work, and another more personal guidance network. We asked with whom of your colleagues do you speak about more personal, more sensitive matters. And 2 years later, we collected again the data. At that point in time, still 12 schools were on board with the project, and about 578 teachers completed the necessary data. At that point in time, we didn't collect network data again because it's pretty intensive, and we already had quite a bit of information from our first point in time. So what were a couple of our key findings of that study? Well, the first big key finding is that those social interactions are indeed a mechanism for transmission. And we also found that the features of these relationships matter. The more you interact with someone, the more or the stronger that contagion effect was. But also multiplexity came into play. And multiplexity basically means that the more layered your relationship is with someone, for example, here in our study, if they went to someone for both information as well as their personal guidance, the contagion effect was much stronger, even stronger than frequency. So if you just interact with a colleague a lot about one of those topics, the effect of contagion is actually less strong than that you would interact with a person to a lesser frequency, but on different topics or on those different aspects, it's different types of relationships. And on top of that, the more embedded you are in that network or in your little group, also the stronger that contagion effect was. So with embeddedness, we mean that the people that you know and that you talk to also talk to each other. If that's the case, the contagion effect is even stronger than just the frequency and the multiplexity. Another thing that we found is that negative feelings were more easily transmitted. So our contagion effect was strongest for emotional exhaustion, but less strong for personal accomplishment, for example. And on top of that, we found long-term effects. So the network that we measured 2 years before and the contagion effect that we've seen there, we're still predicting burnout 2 years later. So it's a really important finding that those social structures in organizations, in this regard schools, not only have an impact at that moment, but can have long-lasting effects on individual teachers. Of course, you can say, but yeah, you talked about social selection. What about that one? Isn't it just the case that people that are experiencing burnout are going towards teachers with other burnout? Our data didn't allow to test for that, but there's literature from other researchers. So there's a study conducted in the Army that actually shows that, yes, that social selection effect is also occurring, but it doesn't explain the whole thing. They found that there were these stress-related circles going on, that yes, people were talking more with people that have similar stress levels, but again, there was also this social contagion effect on top of that. And that happened through 2 different mechanisms. First, people that were experiencing stress were not initiating new relationships, but only maintaining the existing relationships. And those existing relationships were often with people with higher stress levels. So there was this reciprocal effect of both social selection and social contagion that we were seeing in the study here. Another thing is, of course, yeah, but people that are interacting are also usually experiencing the same work stressors. And that's, of course, true. But again, there's other research, this time conducted in ICU environments in hospitals, that were showing that even after controlling for workload as well as job autonomy, the contagion effect was still there. So, okay, what now? We know that social support in organization is a really important buffer for mental health and for burnout. But what do we say now to organizations? Don't connect people with each other? Of course, that's not what we are saying here. I think the first thing is that we are really emphasizing that team level and organizational level interventions need to happen, and that focus on the individual is important, but needs to be supplemented by this. People that have been absent through burnout and that come back have usually, if their therapy has been successful, worked a lot about how they're looking at work and what their potential stressors are, but often face when they return to work that they might have changed, but their environment hasn't. And so the colleagues keep calling on them or keep assuming that they will do the same thing, which makes the return to work really difficult. So hence, yes, of course, equip the individual with the necessary tools and resources, but also look at the team and those interpersonal dynamics that are going on. Social support is a double-edged sword. And a lot of the time we are focusing also on internal aspects, but sometimes the cycle might be already too detrimental and we really need to put a block in it. So it's really important to look at this and see when an internal approach is warranted and the best way to go, but also when there really needs to be external support. Once an individual is really experiencing continued stress-related symptoms and is on its path because it's a long-term process towards burnout, external support might actually be a better way to go than relying on the internal social support. As mentioned, those negative cycles are a lot stronger than the positive ones. So be proactive as an organization rather than reactive. It's better to prevent the harm and to promote the positive, like Professor Lamontagne was also referring to, and then trying to repair the damage afterwards. And then also very generally, co-rumination, in which we keep on discussing the negative things and keep on focusing and overanalyze those situations, is really something that we should try to avoid in organizations, because those are those negative social interactions that are really having an impact on a lot of the employees. And conversely, there's also the protecting the positive, so that we also in other organizations measured energy networks and sharing of positive social experiencing, and that's really important, and we should emphasize on those rather than those negative co-rumination patterns. So what can you do? What does it mean for your organization? Say that you're working in HR and you say, oh, this is an interesting approach, but what can you gain? Well, from doing a network analysis, we would advise you to do one for your organization, because there's ample research showing that not one organization is unique, or it's not like if you have a big organization, this is how your network looks like. That's really not the case. And we measured in organizations both information networks as well as energy networks. And one of the things you can do is, for example, it really allows you, it gives you a map of your organization. It allows you to what it's really internally recognized as a best practice suited for your organization. As Professor Lamontagne said, we know the principles of what we need to do, but it looks very different in every organization. And also the locations or the interpersonal locations where the impact would be biggest are really unique to every organization. It allows you to take a truly proactive approach, because it actually allows you to see where the spread will be, that all stay-in effects that we can actually identify, and see where those negative cycles are occurring, but also where those positive cycles are occurring. It allows you to target your interventions. It doesn't have to be a formal department. It doesn't have, but you can really focus on that informal subgroup, that really close social neighborhood where you might have the most impact. And then, of course, it allows you to work with your social structure, with how your organization is already working, rather than against it, to identify where that internal versus external support might be most suited. So I'm hoping you learned something new today from this alternative perspective on well-being and in social contagion in organizations. And if you still have questions, I'm still happy to have some questions.
It is actually time now, so we'll be moving on to our next speaker after Professor Murray. Thanks, Professor Kind.
Yeah, look, thank you very much, Eva, for a fascinating presentation. I knew you did that sort of work on social networks, but I haven't heard it so clearly explained before. And as you say, it does link up very nicely with Professor Lamontagne's presentation about identifying the details of every given organisation and finding the points of leverage for improving mental health. So thank you very much for a really clear presentation of a complex topic.
Well, we'll move on now to Professor Harry Minnis, who will introduce our next speaker.
Thank you very much, Bruce. Good afternoon to all, and welcome to the final session of this day of wonderful presentations on such a wide range of topics. This final session in the day is focusing on global challenges and opportunities and looking at both a regional approach and also with a focus on some examples of the kind of work that is being done. Our first speaker for this final session is Dr. Ferdinal Fernando. Dr. Fernando is Assistant Director and Head of the Health Division of the Human Development Directorate in the Asean Sociocultural Community Department and in the Asean Secretariat. He's been in that position since 2011, and I've had the privilege of doing some work with Dr. Fernando and his colleagues during much of that time. Under Dr. Fernando's purviews, the facilitation, coordination, initiation, management, and implementation of the ASEAN Health Development Agenda and its work programs, focused on health priorities involving promoting healthy lifestyles, responding to all hazards and emerging strengths, strengthening health systems and access to care, and ensuring food safety. He's been a licensed physician in the Philippines since 1993. He's been engaged with various development work and health-related initiatives at local and international levels for the past 25 years. And it has to be said, I think that ASEAN has taken a substantially increased interest in health across the region, including in mental health. So it's a great pleasure to introduce Dr. Ferdinal Fernando to give his presentation. Dr. Fernando.
Thank you, Professor Harry. It's a pleasure to be invited to this very valuable event and a pleasant day to all of you. Allow me to provide updates on the COVID-19 responses by the ASEAN health sector within the ASEAN region, including mental health related initiatives. Thank you very much for the technical officers in your office or the organizers for assisting me in moving my slide presentation. Moving on, next slide, please. As mentioned by Professor Harry, the Association of Southeast Asian Nations, composed of 10 ASEAN member states or 10 countries, which is in existence for the past 54 years, is a politically cohesive, economically integrated, socially responsible, and truly people-oriented and people-centered and rules-based organization. ASEAN is working towards sustaining its community towards 3 community pillars. These pillars are political security, economic, and socio-cultural community. Health-related initiatives, as well as mental health-related initiatives, are under the socio-cultural community pillar. Next slide, please. Allow me to just present to you what is happening right now in the ASEAN region. Globally, as of this week, there have been more than 236 million confirmed cases of COVID-19, including more than 5 million deaths reported to WHO. Globally, case fatality rate is 2.0, and as shown in the bottom part of the slide, these are regions that demonstrate a general downward trend of cases, but there are countries within these regions that have surge of cases, particularly due to the variants of concern such as the Delta variant. In the ASEAN region, as shown in the upper portion of the slide, according to the COVID-19 situational report by the ASEAN Biodiaspora Virtual Center, there were nearly 12.3 million confirmed cases of COVID-19, with more than 265,000 deaths and a regional case fatality rate of 2.2. This is higher than the global CFR of 2.0. The confirmed cases in the region were 5% of the global cases. The 7-day rolling average of COVID-19 new cases, as shown in the upper portion in our region or ASEAN region, seems to be on the downward trend, but there are still pockets of surges of cases in some areas in the region. Next slide, please. Globally, more than 6.3 billion vaccine doses have been administered. The COVID-19 vaccine report in the ASEAN region indicates that majority of the ASEAN member states or the ASEAN countries have more than 80% of the high-risk population with 1 dose of vaccine. And with ASEAN member states moving towards having more than 50% of the total population with 1 dose of vaccine. As shown in the slide, based on this total population of vaccinated individuals with at least 1 dose, we still are having Brunei, Cambodia, Malaysia, Singapore having that more than 50% statistics or situation. As may be seen from various data sources such as WHO and our ASEAN Biodiaspora Virtual Center, the ASEAN member states have been continually conducting massive vaccine rollouts to achieve at least 10% of the population of every country by September 2021, at least 40% by the end of 2021, and at least 70% by mid-2022, as appealed by our WHO colleagues among its member states. Hopefully, the ASEAN region will be able to move safely or swiftly towards these targets with collective efforts. And speaking of collective efforts, the ASEAN health sector is currently implementing an ASEAN post-2015 health development agenda for 2021 to 2025. This has been informed by the past 5-year work program from 2016 to 2020, and it is composed of 4 ASEAN health clusters. Cluster 1, promoting healthy lifestyle, includes the regional initiatives on mental health, which is basically promotion of mental health in the region. And ASEAN Health Cluster 2 on responding to all hazards and emerging threats. Sorry, next slide, please. Apologies. ASEAN Health Cluster 2, as shown in the lower part of this the slide, is focused on responding to all hazards and emerging threats with various priorities and corresponding initiatives for the next 5 years that would include the COVID-19 response measures, particularly which would include activities on preparedness, prevention, detection, and response. As mentioned earlier, we, the ASEAN health sector, particularly through the support of the ASEAN health ministers, also highly prioritized activities for the promotion of mental health, which is synergized and harmonized with other initiatives under the ASEAN Health Cluster 1 of promoting healthy lifestyle. Next slide, please. Taking off from the ASEAN Health Development Agenda, there have been several initiatives related to promoting mental health. One of this would include initiatives related to, as shown in the table, the development of guideline on integration of mental health in primary and secondary levels of care for ASEAN member states. In ASEAN, the mental health focal points have identified gaps on mental health care and programs in each of the ASEAN countries. And they have also discussed and identified common gaps, which have been categorized into areas on leadership and governance, health system financing, community empowerment, engagement and collaboration, health service delivery, health workforce, data and information system. All of this are still being finalized by our mental health focal points coming from each of the 10 ASEAN countries. The information gathered through their series of consultations and also coordination have identified and have gathered common gaps that were analyzed as part of the initial phase in the development of a technical guideline on integrating mental health in primary and secondary health cares, as well as other settings that would include humanitarian response, including the response to COVID-19. The guideline aims to assist member states in attaining better mental health outcome, and this would include improvement of quality of life, reduction of morbidity and mortality, and limitation of disabilities. Also, in coordination with the Center of Mental Health at University of Melbourne through the Office of Professor Harry, we have also released in 2016 an ASEAN mental health system. This report catalogs the situation of the mental health in ASEAN member states and also provides comprehensive information on the progress made so far by the ASEAN member states in integrating mental health into national health systems and integrating it into access to care and facilitating increases access to care. This guideline aims to assist member states in attaining better mental health outcome. What I mean is this mental health system would guide member states in being informed about improving their mental health systems that is aligned with the priorities of the ASEAN health sector. We have also initiatives that would promote a culture of healthy lifestyle, as well as initiatives that would implement policy brief on mental health in ASEAN. More of this will be discussed in the succeeding slides. As mentioned, in terms of, next slide please, thank you. In terms of the culture of prevention, ASEAN, previous slide, sorry. ASEAN recognizes that the failure to prevent any challenges or to prevent any disasters may lead to a weakening of the resilience of its peoples and as well as communities, and would undermine the ASEAN regional sense of belonging to one community. And this will impact the opportunities of a good life for the rest of the ASEAN. With this particular culture of prevention, and through the political commitment that has been supported through the ASEAN Summit Leaders meeting in 2017, we are currently implementing the ASEAN Declaration on Culture of Prevention for a peaceful, inclusive, resilient, healthy, and harmonized society. Included in this particular declaration would be a culture of healthy lifestyle, which is directly under the purview of the ASEAN health sector. This particular section is being implemented with the main purpose of promoting a healthy lifestyle so as to prevent mental and physical illnesses and disabilities and diseases, as well as dysfunctional habits. Some of the initiatives under this culture of healthy lifestyle are elaborated in some of my presentations later on. Next slide, please. This is a very busy slide, but then I would just like to highlight that in relation to the COVID-19 response, member states through the ASEAN health sector has continuously synergized and scaled up health-related initiatives that would mitigate the impact of COVID-19. And as shown in the slide, in addition to the health portfolio that I have elaborated through the ASEAN Health Development Agenda, there are 27 health-related initiatives on COVID-19 response, which were mobilized as early as January of 2020. This would include initiatives that are already ongoing within the ASEAN Health Development Agenda, such as the ASEAN Emergency Operations Center Network for Public Health Emergencies, or the Network of Disease Surveillance and Laboratory, or initiatives on big data analytics and management, and initiatives on vaccine security and self-reliance. Some of these initiatives would have entry points of coordination and cooperation in relation to promotion of mental health. I would elaborate that also later. There are also initiatives included in this slide that are new health-related initiatives that are being partnered with or cooperated with other countries, such as Japan for the Asean Center for Public Health Emergencies, such as the German government for the Asean Portal for Public Health Emergencies, and also with the US Asean Public Health Emergency Coordination System. Included, or more specifically included in this particular 27 health-related initiatives, next slide please, we would have the ASEAN Center for Public Health Emergencies and Emerging Diseases. You might say this is similar but not the same to a CDC type of institution, wherein this particular center would have its endorsed mandate to be the regional or center of excellence and regional resource hub for the prevention, detection, and response to public health emergencies. Hopefully, with regard to cross-cutting concerns involving mental health intervention, there would be opportunities that this center would also play a part in terms of coordinating mental health collaboration and cooperation with relevant stakeholders. Next slide. I would just like to share that we have the ASEAN Vaccine Security and Self-Reliance and Strategic and its Strategic and Action Plan. This was already an ASEAN commitment by the ASEAN leaders back in 2019 before the pandemic. But it's so fortunate that we already have this regional and strategic action plan that would enable further vaccine rollout among the ASEAN member states. Included in this would be advocacy and promotional activities that would correct misinformation, as well as provide evidence-based information that could be utilized in fake news as well. Now, next slide, please. Thank you. The ASEAN Health Ministers conducted a follow-up special video conference on the ASEAN COVID-19 response after 1 year in July 2022. Included in this commitments and agreements of the ASEAN Health Ministers would be shown in the underlined portion of the right side of the slide, would be fostering greater understanding and implementation of health protocols in the adoption of the new normal, and also to further averting misinformation and fake news. This is a very good commitment wherein there would be a lot of entry points for regional coordination and cooperation with partners on mental health initiatives. Next slide, please. The ASEAN health sector has also, through existing mechanisms, enhanced and sustained its response measures through COVID-19. As shown in this slide, I particularly encircled the ASEAN Emergency Operations Center Network for Public Health Emergencies. This particular network have also been utilized as a platform to share mental health initiatives among ASEAN countries and learning from other neighboring countries as well as other institutions in how mental health challenges have been addressed during this challenging time that started as early as January 2020 in the region. The ASEAN EOC Network for Public Health Emergencies, through the leadership of Malaysia, will continue to coordinate with other stakeholders and include the promotion of mental health in the region as one of its activities in 2022 and onwards. Next slide, please. As shown here, I would just like to reiterate that collaboration and solidarity is very, very critical in this extraordinary global health crisis. And it would require cooperation of the international community and also within the internal environment of the ASEAN region. Next slide. Relevant to this cooperation are the upcoming political commitment that will be adopted by our 10 ASEAN leaders in the last week of October through the ASEAN Summit and its related meetings. There are 2 political documents that will be adopted. This will be the ASEAN +3 Leader Statement on Cooperation on Mental Health among Adolescents and Young Children. This is a cooperation among the 10 ASEAN countries with China, Japan, and Korea. And there would also be a political commitment through the East Asia Summit Leader Statement on Mental Health Cooperation, which is also being led by Australia. I cannot say much about this simply because information on this is still embargoed pending the adoption of these two political commitments in the last week of October 2021. However, I'm sharing this information simply because the stakeholders here would also be involved in the operationalization of these two documents. So these two documents will not remain in paper. They will be operationalized through action plans through relevant sectors in ASEAN, particularly the health sector. So hopefully in the future, we will be able to engage with the other sectors here. Next slide, please. The ASEAN Public Health Coordination System would also be an opportunity to provide entry points of cooperation on mental health. This is with the support of US. And then we will be inviting mental health stakeholders in the consultation of this particular regional coordination system. Next slide, please. The ASEAN Portal for Public Health Emergencies, as launched last July, would also provide a separate layer of platform that would be dedicated to promotion of mental health. And this would be fully utilized by our stakeholders who are also involved in this summit. Next slide, please. In terms of the ASEAN Recovery Framework, this particular framework would definitely provide a reopening, recovery, resilience initiatives among the sectors of the three pillars of ASEAN. One of this would be enhancing health systems. Related to this, next slide, please. Would be various initiatives on the first column that is dedicated to enhancing health systems. And next slide. To be more specific about it, included in this particular strategy one of enhancing health systems would be initiatives that would revisit, redesign, and develop towards evidence-based action plans based on the updated ASEAN mental health systems, and hopefully in coordination with the Office of Professor Harry, as well as revisit and redesign the policy brief on mental health in ASEAN. These two documents will be able to be a good reference for providing evidence-based direction in the implementation of the 5-year work program of the ASEAN health sector, particularly in relation to mental health. Next slide, please. In relation also to this disaster, this health crisis, we have initiatives on mental health and psychosocial support, and an ASEAN protocol on mental health and psychosocial support in disasters is up and coming. And this will be further elevated for implementation next year. And next slide. We also have several webinar series that would produce policy briefs, and these policy briefs would be the source of information to improve our work program in the next 5 years. And we hopefully would like to invite stakeholders here to be part of this webinar series. With that, thank you very much for having me here.
You're muted, Harry.
My apologies. Thank you, Dr. Fernando, for that very comprehensive overview of ASEAN activity in relation to health overall and particularly mental health. I think it will be clear to the participants that there is a great deal of work happening in ASEAN at the moment on advancing mental health throughout the region. This is of great importance to us. The ASEAN countries are our nearest neighbours and among our best friends. And so it's a pleasure to see all of that activity happening. Thank you very much again for your presentation. It's a pleasure now to introduce the second speaker in this final session, a dear friend and colleague, Dr. Sudipto Chatterjee, Dr. Chatterjee is a psychiatrist based in Bangalore, India at the National Institute of Advanced Studies. He's a consultant to the Special Initiative in mental health programs of the WHO, and also associated with the Parivartan Trust, non-government organisation in India that has been doing remarkable work now for quite a number of years, particularly at community levels. He's made important and original scientific contributions in relation to developing community-based care for people with serious and common mental disorders in low-resource settings in India and across a number of low and middle-income countries, while consulting for WHO and also while working together with colleagues at the University of Melbourne. He's also been involved in clinical trials involving treatments for common and serious mental disorders that have been published in high impact scientific journals and that have been globally influential. His continued interests include efforts to reduce the treatment gap and enhance the social inclusion of people with serious mental disorders effectively and at scale, and particularly in low resource settings. It's a particular pleasure, Sudipto, to welcome you to this day, and thank you very much for your presentation. Over to you.
Thank you, Harry, and thank you for your kind introduction. It's a real honor and privilege to be speaking at the World Mental Health Day Summit of the Mental Health Foundation of Australia, partly because I've spent a bit of my professional life, actually quite a bit of my professional life working in Australia, and I have very fond memories of the time that I spent there. So it's really nice to be able to speak at this forum. When Harry invited me to speak at the forum and with a particular topic in mind, I kind of thought about it a bit, and there were two things that I decided. One is that I'll probably speak a little bit about the context in India and surrounding low-income countries around mental health pre-COVID. Then talk a little bit about what COVID has done to this particular ecosystem, and focus probably a substantial part of my talk to the emerging trends, because that is of real interest and I think has transformative value in thinking about mental health in the region and globally. We're all very familiar, I think, with the extreme resilience that is called for in attending protracted meetings on online platforms. So I'll stick to time, I'll be brief, and I will outline what I think are the most important things without a set of slides. So just to set the context, I think it's important that we realize that much before COVID, mental health, as we all know, has been not such a great priority for many low resource and low income country settings. And what that has meant is that the low investment in mental health generally means that there are enormous treatment gaps. There are mental health problems are common, disabling, and contribute very large proportion of the global disability, including in countries like India. But unfortunately, for a variety of reasons that I think we're all familiar with, mental health has not had the priority and the response and the investment that is required to respond to the epidemiological scale of the problem. So in effect, very large sections of people with mental health problems, serious mental health problems, common mental disorders, and are essentially denied access to services. And what that means is they're untreated, there are mounting disabilities, there is a range of social exclusion that happens, there is widespread stigma, lack of employment opportunities. So there is a real crisis that existed in mental health of countries like India and other neighboring and low resource countries much before COVID happened. The impact of the COVID pandemic, as you're well aware, and many of my co-panelists have described in very great detail, has been catastrophic in many senses for already fragile health systems. One of the analogies, it's not a great analogy, but I think it sums it up properly, is COVID is pretty much like the wildfires that you have experienced in Australia, got out of control and decimated, battered and bruised already fragile health systems. And the consequences of that have been, I think, very clear in terms of mortality, in terms of the great numbers of people who were left pretty much on their own in trying to deal with infections in their relatives, amongst themselves, and all of that. But there's also been a huge social cost. The social costs of the abrupt and the very severe lockdown that happened in India at the initiation of the COVID pandemic left large parts of the population without access to housing, access to employment, access to food security, and led to enormous increase in risk factors. In fact, it was a perfect storm of risk factors that were created on a very large social scale, which obviously had a great impact on the mental health and well-being of the population. So the experience of COVID has, in effect, accentuated and deepened the already existing inadequacies of the health system in terms of dealing with people with, in terms of responding to people with mental health problems in an effective manner and at scale. And this realization, I think, that the health and the social impact and the impact on well-being on whole populations, including front care health workers, including people affected by COVID, their relatives, their communities, has, in some senses, been a transformative moment for mental health in the region and in many parts of the world. There is now an unprecedented understanding that mental health is important. Mental health is a public good. Mental health requires substantial investment and support at the very highest levels of the political entities. And this is probably illustrated by the fact that the Honorable Prime Minister of India has personally invested in making sure that mental health is given the highest priority in terms of services, in terms of funding, and in terms of new ways of thinking how this can be accomplished better, bigger, and in a more responsive manner. The second, I think, very important thing that has happened in the context of COVID and the disruptions that have been caused is a much better understanding at political levels about this whole issue of social determinants. The fact that poverty, loss of livelihood, loss of social connectedness through the isolation that was imposed for very long periods, the impact that it has had on schooling, on work, and a variety of other such social determinants, I think there is, again, unprecedented understanding that these are important drivers of mental health of populations. And for decades, I think people like Harry and me and many of you in the panel, I think, have talked about the fact that there needs to be a greater understanding and focus on social determinants and how they shape and influence mental health in population levels. But I think the traction that was available wasn't so great. But in this particular context, I see that there is, in India, for example, there is much greater sensitivity to mental health in the health system. For example, for people who do get infected by COVID and are placed in home isolation, and I can say this from my personal experience, for the very first time, as part of the triage and assessment and the follow-up, mental health, basic questions on mental health: how are you feeling? Don't get anxious, things can be under control, there are things that can be done. These messages were built in at very large scale across all counseling services that were provided. And this is a big breakthrough. This has never happened in the context of health. And again, from the receiving end, just a few words from the person across on the telephone line, the impact that it has, that the kind of reassurance that has brought this thing to the fore that mental health needs to be integrated in every aspect of health delivery. There is much greater understanding of this in the non-communicable disease fraternity, in the mother and child initiatives, where very clear and very specific interventions or at least assessments around mental health are now being made part of the protocol. So in health systems in general, there is, I think, an unprecedented awareness and opportunities for psychiatrists, for professional groups to get involved and to talk about population-based public health, mental health initiatives. And I think that's actually a transformative event in how mental health can be reconceptualized. The other good thing that has happened around this whole pandemic and the situation that has arisen from that is the idea of social isolation. The catastrophic impact of social isolation on the vulnerable, the elderly, school-going kids, children who are stuck at home for 2 years without access to play, peer socialization, and things of that nature, without access to real schools. The fact that almost the entirety of schooling in India has shifted to online virtual schooling. But we must remember that not everybody in India has access to instruments to take advantage of these online schoolings. And very large sections of young Indian children have been, the educational impact has been truly enormous. And there is going to be a lot of effort that is going to be required to address this. I'm very glad to hear that Asean has focused on child and adolescent mental health as a priority, because this has impacted children and adolescents greatly. And if left unaddressed, it has the potential for causing many problems in this cohort of young people in the years to come. Similarly, I think there's been the other thing which is really exciting as part of the recovery from COVID and the responses to that is that mental health has truly come out of the shadows and become everybody's business. I know this is cliched slogans that have been around for a while, but these are actually happening in workplaces, in schools, in community organizations, in communities itself. There is now a very clear understanding that everybody needs to get involved in this whole issue of mental health. It's not just about professionals, not about health systems. It is about whole of society. And I think the Sustainable Development Goals, that framework provides a wonderful opportunity for mental health to be prioritized as part of a public good that is important for achieving Sustainable Development Goals in the future. And I think that this has happened for the very first time. People from sectors like developmental sectors who we kind of approached and talked about the importance of mental health in development with very little actual outcomes are now sensitized and are approaching us in terms of, how can things be done better? How can people with mental health disorders and problems be centrally included as highly vulnerable groups within this larger developmental process? And how can they be included? Because there's an understanding that without that happening, they will be left behind. They have been left behind, they will be left behind, but now there is an opportunity for us to look at ways of how social inclusion can be promoted with people with mental health problems. There is, in workplaces, for example, I was listening to some of the earlier presentations on workplace social contagion, very, very interesting stuff. But there is now a grassroots movement which is coming from the end users to talk about mental health. How can offices be restructured? How can health promoting schools, colleges, offices be constructed? And that is a great opportunity. That is a wonderful opening up of the sector of mental health and well-being, which is being driven for a change by community organizations, by various companies, large, small, medium, and across the educational sector. So I think overall, the fact that mental health has now become a public talking point, a point where everybody is invested in, everybody sees the need for mental health to be a central part of whatever agenda of health, development, social cohesion that low-income countries, low and middle-income countries need to invest in. Certainly that part has been catalyzed. And these present absolutely incredible opportunities for this to be actualized on the ground. I think we've talked about it. I think we have very good evidence, again, largely from the global south, as to what can be done. How can employment, how can social inclusion, how can inclusion and development be actually implemented? So we do have some idea of what needs to be done. But now there is an amazing opportunity to actually interact with the very highest levels of policy, with political commitment, with political will, with fundings, with support for these kinds of initiatives to be actually translated into real life kind of settings. So in a sense, this has been a revelation. This is, in my professional life, and I can say, for many of us who have worked in contexts that have low resources, there has never been a time where mental health has been given the kind of priority, the kind of direction, the kind of importance so in a sense, it is a wonderful opportunity. And I think as professional bodies, as foundations like this, there are great opportunities for engagement. There is a great opportunity for bringing that body of evidence to the attention of policymakers, to the attention of health planners, to across workplaces, schools, for example, and very importantly, at the lowest levels of governance and in the community, where now people are willing to talk about mental health of their communities and invest in it financially and with human resources to address these problems. So I think the COVID pandemic has, we've had, it's been a century, the 1918, the pandemic, and we've had almost a century of developments in the mental health field. We've moved from the wholesale export of the institutional-based treatment to many low-resource countries as part of the colonization project. We've had a move towards, tentative moves towards deinstitutionalization, towards community-based mental health care. And now I think in a century that has elapsed since then, there is an opportunity to reimagine how mental health and mental health services can be implemented using a whole of society approach. And I think that's very similar to what the Royal Commission, the recent Royal Commission has recommended as well, that it's not just about treatments and services delivered in professional settings. Mental health involves a lot more and everybody can get involved. So I think that there is a real congruence of ideas around how mental health can be reimagined, how it can be restructured, and it presents, as I said, opportunities that bodies like us, people who have been working in public mental health in low-resource countries would necessarily have to engage in. So in conclusion, I'd like to say that, yes, there are challenges. Yes, the scale and the extent of the challenges are now much clearer than they have been ever. But on the other hand, there are opportunities, there are ways to address these challenges. And for me, truly, this is an interesting and a very exciting time to be working in this area of mental health in low-resource countries. And I think that as professionals, this is a great opportunity for us to engage and be part of the discussion on how mental health can be revitalized, reconceptualized, made person-centric, and all the other kind of things that we have so far desired and talked about. So thank you very much, Harry, for giving me this opportunity. And it's been really nice to talk. Thank you very much.
Thank you, Sudipto, for a really eloquent statement of both the magnitude of the challenges, but with a real focus on the opportunities that are before us. In a sense, the magnitude of the opportunities also represents to those who are involved in this a massive challenge, and how to actually realize those opportunities, how to make the most of this moment in time when mental health is on everybody's mind, in order to bring about the kind of improvements that we would all like to see. Thank you, Sudipto. Thank you to both Dr. Fernando and Dr. Chatterjee in this final session. I'm particularly pleased that what we heard from both speakers was the remarkable opportunities right across Asean and neighbouring countries, and the kind of opportunities that Dr. Chatterjee talked about in terms of reimagining, reconfiguring, reconceptualising how we go about the business of improving population mental health. Bruce, thank you, and over to you.
Thank you indeed, Professor Minnis. Thanks, Harry, for your leadership and organising this most important global perspective. It's interesting, as you say, and thanks, Dr. Chatterjee, for both emphasising the adverse impact of the pandemic, which has been a major feature today, but also giving us some hope and a challenge about how we can all bring this to the forefront of the whole population for everybody's betterment. Well, an online conference is a challenge for those that organise it, and also for those that join it. We must attend to dense information, but today has been, from my point of view, an absolute success. It has been a tour de force, indeed, in covering a whole number of issues from early childhood, youth, adulthood and ageing, and from a multicultural perspective as well. We've had a biological perspective input, psychological, psychosocial and cultural, giving us a full and comprehensive views of the challenges, and there's no doubt about it that COVID has brought huge impacts and challenges for mental health, and what are some of the factors involved in that. For the impact, it's now, it's real, it's upon us, but we've also been reminded of long COVID, of the longer term outcomes that we must look for, be prepared for, and provide prevention and early interventions. It's also brought to mind the various inequities in services, in cultures, in society, and in a whole range of other areas which work against those who are in inequitable situations in terms of their own mental health. But it's also brought a number of opportunities, and in particular, there is a good deal of hope about using this opportunity, as human beings are wont to do, to make the best of it and to imagine a new and better world. And from that imagining to actually innovate. And we've heard of some great innovations already today. We've heard of the school integrated recovery platform. What a fabulous idea. We've heard about the importance of parenting support, multi-level and evidence-based, already in operation. We've heard about proposals and pilot projects of women's and children's mental health clinics to provide a safe place for an inequitable range of services for women and children. We've heard about multi-service support hubs, and this resonates very much with the Mental Health Foundation Australia because of our own very real and well-advanced plans to develop a demonstration mental health promotion hub, initially in Melbourne, but then spreading to other states. Watch this space. We've heard about the importance of social contagion, how it can be both a positive, but more importantly, a negative activity, which we must guard for and provide early intervention and prevention in the workplace. And finally, we've heard about self-determined, safe support services, particularly for groups such as our own Aboriginal Torres Strait Islander groups, but also for refugee and other multicultural groups. We need to provide safe, self-determined, culturally sensitive supports for many in the Australian population. So that's the end of the World Mental Health Day Summit. But in conclusion, I'd like to thank all the speakers who put themselves out enormously to present very thoughtful, insightful and challenging information, to the chairs of each of the sections who've organised the speakers and have chaired those sections, and then to our own administration, to our chairperson, Vasan Srinivasan, and deputy chairperson, Mr. Jim Gooden, to the manager of the foundation, Aisha Usman, to the team, both the paid staff, but importantly, you may be interested to know that we've got a whole host of volunteers behind today and during the Mental Health Month, which are making this month work. Thank you to all of you. We thank the multicultural, the youth, and the scientific advisory leaders and committees which enrich our information and our presentations and our innovative vision for the future of mental health in Australia and beyond. I just remind you of Mental Health Walk, the National Walk for Mental Health on the 17th of October. Exercise is a promotion of mental health. Get in there and do it every day, actually, if you can, but in particular, join us on the 17th of October. I'd like to mention today the appeal that the Mental Health Foundation has launched. Please be generous. We need money to promote mental health. It isn't going to all come from, in fact, lots of it will not come from government. It must come from community action. There might be some of you who today might have been more than you expected to be challenged by what you've heard. If you're feeling fragile yourself or need to talk to somebody, you need to link in with support services. Please don't hesitate to call our Mental Health Foundation Australia helpline, or call Lifeline or Kids Healthline, or a number of other support services that are available, including your own general practitioner. Do not hold back on that. Do not be ashamed to seek help. Seeking help is one of the first starts in recovering and managing the stress that we're all under. Thank you for your attendance. It's been my privilege to chair this activity today, and I wish you all a good and happy evening. And I hope that today you've experienced someone being kind to you and you're enabled yourself to be kind to somebody else. Good evening.